Hiya, welcome to Biomed Sessions with me, Ruz. Today we are going to be discussing hyponatremia. Hypo means low, emia means relating to a substance in blood, and natrium is the Latin word for sodium. Hence, hyponatremia refers to low levels of sodium in the blood. It is a common and serious electrolyte disorder which can progress anywhere from being asymptomatic to manifesting with fatigue, headaches, and vomiting, and going on to confusion, seizures, coma, and even death. Elderly and hospitalized patients are the most commonly affected. However, no one is excluded, and it is even known to occur amongst marathon runners. The body usually keeps blood sodium concentration within a tight range with the help of water. Hence, we need to have a good understanding of the relationship between sodium and water in the body, which would also include the concept of osmolality, which is vital in figuring out what is causing hyponatremia. Therefore, I will explain these topics, then go on to discuss the classification, investigations, and management of hyponatremia. Okay, so the term intracellular fluid generally refers to the total amount of fluid located inside all cells. And remember, we have trillions of them. Intracellular fluid consists mostly of water with electrolytes, proteins, and small molecules. Extracellular fluid refers to all fluid not contained within cells, i.e. outside cells. This can be further subdivided into intravascular fluid, which is the plasma that is found within all blood vessels, and interstitial fluid, which essentially is just the filtrate of plasma. In other words, fluid which leaks through the walls of capillary blood vessels. We also have a tiny amount of transcellular fluid, which is contained within separate spaces. But as this makes up less than 3% of the total extracellular volume, I am not going to refer to it within this video. However, for further information, check out the FAQs below. If the black dots represent sodium, look at the significant difference between the average intracellular and extracellular sodium concentration, measured in millimoles per liter. Most sodium is located outside of cells because the cell membrane is like a security guard, which makes charged particles wait in line, only allowing sodium in or out via pumps or channels, but allowing water to enter and exit the cell freely. The reason why the concentration of sodium in blood plasma is fairly similar to the interstitial fluid is that there are wide gaps in the walls of capillary blood vessels, which allow most contents of plasma to leak through, apart from red blood cells and plasma proteins, which are larger in size. Hence, these two spaces have a similar makeup. Despite the different composition of the intracellular fluid in comparison to extracellular fluid, the osmolality is usually the same. Osmolality, in simple terms, is a measure of the number of solutes, i.e. dissolved particles, per 1 kilogram of solution. Our solution here is water. The body likes to keep the osmolality of both intracellular and extracellular fluid equal and at around 280 milliosmoles per kilogram. Note, we also have osmolarity with an R, which is a measure of the number of solutes per liter of solution. But in this context, osmolality is more accurate. To understand osmolality, we need to acknowledge that sodium isn't the only solute present. I will use grey squares to represent other solutes, which includes multiple substances such as other electrolytes, for example, potassium, and molecules such as glucose. This grid represents 1 kilogram of water intracellularly, and this one, 1 kilogram of water extracellularly. As you can see, despite the different compositions, the overall number of solutes is the same. Therefore, the osmolality is the same. Sodium is the most abundant cation in the extracellular fluid. Therefore, changes in sodium levels usually have the biggest impact on osmolality. In most cases of hyponatremia, there are less extracellular sodium ions per kilogram of water, which means the total number of solutes per kilogram is reduced, i.e. extracellular osmolality is comparatively lower. This can happen as a result of excess water diluting out the solutes or a lack of sodium. In either case, there's just too much water for the amount of solutes present. The body hates uneven osmolality. Thus, water will shift out of the extracellular fluid into the cells by osmosis, evening out the osmolality. When water moves into the cells, they increase in size. Remember, cells are everywhere. So with that in mind, it's a big problem when fluid shifts into brain cells, causing them to swell, officially known as cerebral edema. This is because the skull only has a fixed capacity and cannot accommodate excess swelling without neurological consequences. And if the intracranial pressure continues to build up, the brain can herniate through the base of the skull, leading to coma and death. The main hormone/hormone systems mentioned alongside hyponatremia are antidiuretic hormone, ADH, and the renin-angiotensin-aldosterone system, RAAS. Having a basic understanding of these will help you interpret investigations. ADH is secreted in response to a number of situations, including decreased blood volume. It mainly acts on the kidneys, specifically on nephrons, enabling more water to be reabsorbed back into the body, meaning less passes out as urine. For more information on this, check out our function of the nephron video. RAAS is a multi-step system where the main players are the hormones renin, angiotensin, and aldosterone. This system is triggered largely in response to a drop in blood pressure/blood volume detected by baroreceptors and/or a decrease in blood sodium levels detected in the kidney. RAAS increases sodium reabsorption back into the body from the kidney, and naturally where sodium goes, water follows. Note, it can also stimulate thirst, compelling people to drink more fluid. Both RAAS and ADH are additionally involved in constriction of blood vessels to increase blood pressure. ADH is often the bigger culprit in hyponatremia, as it is not involved in sodium reabsorption, rather dilutes the blood sodium content with free water, i.e. water without solutes. A blood sodium less than 135 millimoles per litre is diagnostic for hyponatremia, 130 to 135 being mild, 125 to 129 being moderate, and less than 125 being severe. The lower the sodium, the worse the symptoms. Chronic hyponatremia is when sodium levels drop at a slow rate over 48 hours or longer, whereas in acute hyponatremia, sodium levels drop quickly in less than 48 hours. Acute hyponatremia leads to rapid shifts of fluid into brain cells. This needs to be treated as a matter of urgency. As chronic hyponatremia develops more slowly, it gives the body more time to adapt. So for the same level of blood sodium, patients with chronic hyponatremia may have milder symptoms than those with acute hyponatremia. Hyponatremia is not a disease in itself. It is just a clue. To find out the underlying cause, we need to interpret the history, examinations, and investigations properly. After noting a low blood sodium, the three main steps are 1. Looking into plasma osmolality, 2. Assessing fluid status, 3. Urine investigations, as in urine osmolality and sodium. Step 1. Look at plasma osmolality to differentiate between true hyponatremia and other types. As mentioned previously, in most cases of hyponatremia, there is also low plasma osmolality. This is referred to as hypotonic hyponatremia, although many people call this true hyponatremia. The less frequently occurring types of hyponatremia are isotonic and hypertonic. Isotonic hyponatremia is where there is a normal plasma osmolality. This can be due to a lab measurement error relating to an excess of lipids, hyperlipidemia, or proteins, hyperproteinemia. These substances displace water containing sodium and essentially mess up the calculations of older lab techniques, which use overall volume to estimate sodium levels. Hence, we get false readings of hyponatremia. This is known as pseudo-hyponatremia, essentially fake hyponatremia. Treating this as a real sodium imbalance rather than a lab error could cause harm. An isotonic hyponatremia can actually occur when the extracellular space is expanded with an isotonic fluid, which does not contain sodium. For example, during surgical procedures where isotonic mannitol is used as bladder irrigation in such large volumes that it is absorbed into the body. In this case, mannitol will take up some extracellular space. Therefore, the concentration of sodium will be lower. But there will be no shift of fluid into the cells because the fluid being given does not change the osmolality of the extracellular space, as it has the same number of solute particles per kilogram, despite there being a lesser proportion of sodium. Hypertonic hyponatremia, which has a high osmolality, usually occurs in the presence of hyperglycemia, i.e. excess glucose molecules, or upon the infusion of intravenous fluids with a high osmolality, such as hypertonic mannitol. Don't get this confused with isotonic mannitol. The excessive substances such as glucose essentially increase osmolality of the extracellular space and reduce sodium concentration. The increased osmolality causes water to be drawn out of the cells in order to even out the osmolality by concentrating intracellular fluid and diluting the extracellular fluid. Just before we get into the rest of the video, which will be geared towards finding the underlying cause of true hyponatremia, aka hypotonic hyponatremia, which accounts for most cases, if you are finding this video useful and enjoy complex topics being made easy, then click the subscribe button and notification bell to stay up to date with new videos. It's absolutely free. Plus, we would love to get to 50k subscribers by the end of the year. Thank you. Now back to the video. Okay, so once we know we have a hypotonic hyponatremia due to low plasma osmolality, step 2 in our process of diagnosis is to determine a patient's fluid status. Are they hypovolemic, i.e. lacking body fluid? Are they hypervolemic, i.e. fluid overloaded? Or are they euvolemic, i.e. appearing to have a normal amount of body fluid? This information, which can be obtained by simple physical examination and review of bedside charts, is a vital clue to the underlying cause of hyponatremia. Let's break it down category by category. Hypovolemic literally means low volume of blood. Hence, hypovolemic hyponatremia occurs in conditions that deplete the body of fluid. Clinical signs include dry skin and mucous membranes, reduced skin turgor, tachycardia, and low blood pressure. With this type of hyponatremia, there is a decrease in the total body water, but an even greater drop in sodium. Underlying causes can be split into 2 categories, renal and extrarenal, i.e. those which originate in the kidneys and those which don't. Looking at the extrarenal first, this includes severe diarrhea and vomiting, whereby there are gastrointestinal losses of water and electrolytes, including sodium, and burns, whereby thermal injury leads to a widespread inflammatory response and subsequent changes to cell and blood vessel permeability, causing fluid shifts and electrolyte imbalances. A very common renal cause of hyponatremia is thiazide use. Thiazide diuretics are thought to cause hyponatremia through a number of mechanisms, which include inhibiting reabsorption of sodium and impairment of water excretion from the kidneys. Primary adrenal insufficiency is a less common cause in which inadequate production by the adrenal gland of the mineralocorticoid hormone aldosterone leads to sodium and consequently water being lost via the kidneys. Also, in this condition, there is a lack of cortisol, which is a glucocorticoid hormone which usually suppresses ADH release. In the absence of cortisol, ADH has even more freedom to dilute blood with water. There are also renal salt wasting conditions which cause volume depletion due to abnormalities in sodium transport. Step 3. Let's take a look at the patient's urine. First, urine osmolality, which gives an insight into ADH activity. In hypovolemia, you will expect concentrated urine with an osmolality of over 100 milliosmoles per kilogram, as the body wants to restore the blood volume, so it deploys ADH to aid in water reabsorption in the kidneys. Next, urine sodium, which is the actual differentiator here. A low urine sodium of less than or equal to 30 millimoles per litre alongside hypovolemia suggests an extrarenal cause of hyponatremia. As you could imagine, the kidneys might want to hang on to sodium if it is being lost through other sources such as the gastrointestinal tract. Hence, RAAS is activated and the kidneys reabsorb more sodium and less passes out in the urine. A higher urine sodium of over 30 millimoles per litre alongside hypovolemia suggests a renal cause of hyponatremia. Naturally, anything that reduces or blocks the reabsorption of sodium in the kidney will lead to higher amounts found in the urine, hence the high urine sodium with thiazide diuretic use and in primary adrenal insufficiency. In hypervolemic, i.e. high volume hyponatremia, both body sodium and water increase, but the proportion of water increases more. Clinical signs of fluid overload include edema, ascites, raised JVP, and crackles at the lung bases. It might seem counterintuitive, but despite the overall increase in body fluid, the intravascular volume is reduced, just like in hypovolemic hyponatremia. Basically, there is a lot of fluid on board, just not enough in the blood vessels. Edema essentially signifies an excess collection of fluid in the interstitial space. This happens because there is an increased hydrostatic pressure within the capillaries, meaning that fluid is pushed out. And additionally, there is a loss of plasma proteins, which are usually responsible for oncotic pressure, a force which pulls fluid into blood vessels. Examples of hypovolemic hyponatremia include congestive heart failure, liver cirrhosis, nephrotic syndrome, and renal failure. Because of the reduced intravascular volume, RAAS is triggered as well as ADH. Therefore, urine osmolality will be over 100 milliosmoles per kilogram as a result of ADH action, and urine sodium will be low, less than or equal to 30 millimoles per litre as a result of RAAS, causing sodium reabsorption. The exception here is renal failure, where the kidneys are essentially just messed up. This can have a variable urine sodium level, so it is better to look at creatinine levels if you suspect this, as these will be deranged in someone with renal failure. On that note, urine sodium may be difficult to interpret in general if a patient has a background of diuretic use or renal failure. In euvolemic hyponatremia, total body water increases, but total sodium remains the same, so the excess water dilutes the blood. The increase in the extracellular volume is not enough to be detected clinically, so patients appear neither overloaded nor depleted of fluid. The most common cause of euvolemic hyponatremia is SIADH, i.e. syndrome of inappropriate ADH, where excessive ADH is secreted. However, this is a diagnosis of exclusion, therefore other causes need to be ruled out first. Because SIADH is special, we'll give it a little more attention later. Other causes of inappropriate ADH release are thought to include glucocorticoid deficiency and hypothyroidism, although newer studies challenge hypothyroidism as a cause for hyponatremia as opposed to just an association. As mentioned previously, cortisol is a glucocorticoid hormone which suppresses ADH. Therefore, if it is deficient, there will be excess ADH leading to the blood being diluted with water. As for other causes of euvolemic hyponatremia to rule out before considering SIADH, we have primary polydipsia, a condition where an individual drinks way too much fluid and the kidneys may not be able to work fast enough to get rid of the excess. Hence, the blood is diluted with water. Beer-potomania, where large quantities of alcohol, particularly beer, which doesn't have much sodium, is consumed alongside the patient not eating much, therefore having a low solute intake, which results in blood which lacks sodium. We also get a similar outcome in malnourished patients with a low sodium and protein diet, which some refer to as the tea and toast diet. And as mentioned previously, hyponatremia is known to occur amongst marathon runners. This can happen if they sweat large amounts, thereby losing sodium, but replace lost fluid by drinking excessive water, thus leading to more dilute blood. For euvolemic hyponatremia, urine osmolality is a better differentiator than urine sodium. Urine osmolality will be over 100 milliosmoles per kilogram in conditions where there is inappropriate ADH release, as there is increased reabsorption of water back into the body from the kidneys. Whereas urine osmolality will be low, less than or equal to 100 milliosmoles per kilogram, in conditions where water intake is in excess, because the kidneys are trying to urinate out the excess water, and ADH is appropriately suppressed because there is no need to reabsorb water. Of course, if you suspect euvolemic hyponatremia, do the appropriate investigations to rule out certain causes. For example, a morning blood cortisol level if you are suspecting glucocorticoid deficiency. Now getting onto the big boss, SIADH, which is also just a clue to an underlying diagnosis. There is a ridiculously large amount of stuff that can cause SIADH, so I will just highlight the main categories. Malignancies, e.g. small cell lung cancer, lung diseases, e.g. pneumonia, central nervous system disorders, e.g. meningitis, and certain drugs, e.g. anti-epileptic medications and the recreational drug ecstasy. Based on these possibilities, you may understand that ordering a chest x-ray and asking the patient's medication/drug use may be helpful as first steps towards figuring out what's going on. Okay, so what's the treatment approach when it comes to hyponatremia? Essentially treat the underlying cause, otherwise the hyponatremia is likely to persist/worsen. Don't worry, we have already talked about everything written here. So for hypovolemic hyponatremia, we will want to restore volume with isotonic fluids, e.g. normal saline. We would also want to stop or withhold thiazide diuretics if we think this is the offending agent. Steroid replacement therapy is needed for adrenal insufficiency as aldosterone and cortisol are steroid hormones. For hypervolemic hyponatremia, we would want to manage the underlying condition appropriately. We would want to restrict salt and water intake because the patient has too much fluid on board, so giving fluid would just worsen edema. Loop diuretics may be used here to offload some fluid. In terms of euvolemic hyponatremia, we can fluid restrict patients with primary polydipsia, give steroids in glucocorticoid deficiency, and ensure adequate nutrition for those with poor solute intake and alcohol counselling if needed. For SIADH, generally fluid restriction is required whilst we try to figure out and fix the underlying cause. Vaptans are medications which hinder the activity of ADH, thus can be considered for use in both euvolemic and hypervolemic hyponatremia. Ideally, plasma sodium correction should be gradual as correcting too quickly can lead to the complication osmotic demyelination syndrome, which can cause permanent disability and, in a proportion of cases, death. To more or less explain this, we need to understand that with hyponatremia, the brain cells are surrounded by extracellular fluid that has a low osmolality due to decreased sodium concentration. To somewhat improve this situation, brain cells gradually pump out some of their solutes, slightly increasing the osmolality of the extracellular environment. Thus, some water also moves out of the cells, alleviating some of the cellular swelling. When treating hyponatremia, if plasma sodium level is increased too quickly, the osmolality of the extracellular fluid becomes way too high in comparison to intracellular osmolality. And because the brain cells are not able to take up solutes at a fast pace, there is instead a rapid shift of water out of the cells to even out the osmolality. This rapid fluid shift further shrinks the cells and puts them under strain, leading to loss of their myelin sheath and the complications described. When managing hyponatremia, we need to weigh up the seriousness of symptoms versus the risk of osmotic demyelination syndrome. Acute hyponatremia, presenting with neurological symptoms such as seizures, is a medical emergency and needs to be initially treated more aggressively than chronic hyponatremia. This can involve the use of hypertonic saline or salt administration, although blood sodium levels would need to be checked frequently. Guidelines vary and should always be checked, but generally speaking, the rate of plasma sodium correction should not exceed 12 millimoles per litre within the first 24 hours. And in an ideal situation, we would be aiming for a rise between 6 and 8 millimoles per litre per 24 hours. Remember, correct sodium slowly if you can. Want to understand how the kidney works? Check out our function of the nephron video. Alternatively, take a look at one of our other Made Easy videos. See you there.